if you have joined, please write your name. Let's begin. The earlier we start and finish, the better. Okay. Okay. I can see one person has joined. So the class has 12 people. So I need to see at least 6 before I begin. Sorry for the light. With this grid collapse, I cannot use more light. I have to manage the light I have. So manage this. Okay, 2 people are here. I need 6 people to be here. Please, if you have joined, write your name so that I know who is here. Write your name in the comment section so that I know who is here. All right, I will begin. If you're here, please write your name. Let me know. Let me know who is here. Okay. Adetola is here. Good evening. Who else? I need at least 6 people so as to begin. Today, we are going to deal with all endocrine questions. I may not ask or deal with the endocrine question as you know, but we will do endocrine questions similar to the things you were asked during your exams, so that if you get this kind of questions, you will not have difficulty. So if you're here, please write your name. We have 4 people. I need at least 6 people so that I'll begin. After trashing out endocrine questions, we'll go to, okay, I can see up to 16 people. Please write your name. Let me know who is here so that it will be more interactive than this. Try and write your name. Abdullah Toro is here. You're welcome. Who else? So if you can hear me loud and clear, say I can hear you. Adetola, if you can hear me, please write something. Then I will begin. We cannot continue to wait. So if you can hear me, say loud and clear. Just write loud and clear so that I can begin the discussion. So I'd like to, I can. So if you can hear me, okay. All right. So you can all hear me. Good. So let's begin. So please, it is important that all of you have paper and pen for this discussion, because it will be more of interactive, right? So it will be better if you have paper and pen. That's the way that we can interact better. Okay, so we'll go with the first question. Please pay attention, because you are the one that will give me answer, then I will explain the answer. All right. So first question: a 18-year-old man presented to the emergency with the symptoms of polyuria, polydipsia, and body weakness. The patient had on examination nothing remarkable, and the patient was just mildly dehydrated. So the patient was just mildly dehydrated. Okay. So the BMI of the patient was 30 kilogram per meter square. The waist circumference was 120 centimeters. The blood pressure was 140 over 80, and the HbA1c was 6.1%. So let me repeat the important findings. I say it's an 18-year-old. He presented with polyuria, polydipsia, and polyphagia. He had no remarkable thing on examination. Aisha is here. Sumaya is here. No remarkable thing on examination, but the BMI was 30 kilogram per meter square. The waist circumference was 120. The blood pressure was 140 over 80, and the HbA1c was 6.1. The question here is, what is your diagnosis? A. Type 2 diabetes. B. Hypertension. C. Type 1 diabetes. D. Metabolic syndrome. And E. None of the above. So the question are: A. Type 2 diabetes. B. Hypertension. C. Type 1 diabetes. D. Metabolic syndrome. And E. None of the above. What is the answer? So type the answer so that we can discuss. If you know the answer, please type it. What is the answer? Okay, very good. So the answer is metabolic syndrome. So let's discuss metabolic syndrome. The criteria that defines metabolic syndrome includes the waist circumference in men greater than 102 and the waist circumference in female greater than 88. This is a prerequisite. So if you're talking about the criteria of metabolic syndrome, you must, I repeat, you mention uh, the waist circumference. Then secondly, remember in lipid profile, there is no LDL. It's just low HDL and high TG. There is no LDL. There is no total cholesterol because there is likelihood that you can be asked in your orals or interactions during your clinicals. So there is no LDL or total cholesterol. It's just low HDL and uh, high TG, right? Then the BP will be at the definition of hypertension 140 over 90, or if the individual is already on antihypertensive, is also a criteria. Then you talk about any dysglycemia. So it doesn't have to be type 2 diabetes for it to be part of metabolic syndrome, either pre-diabetes or diabetes. Very important for all of you. Watch my videos on this YouTube because I remember during your final exam, some of you, when they took you to the glucometer station, and I say if the value of fasting is 6.1, what is it? A lot of people did not know. So in my videos in this YouTube, there are a lot of important information, basic information, because most of these old consultants, they will be asking you very basic things. They will not go to high floating stuff. So it will be wise if you watch. Okay, so this is the criteria for metabolic syndrome. Though there is issue of elevated uric acid, but all those ones are supportive. Okay. So if you understand the answer, please, I think how many people answered? One, two, three, four. If anybody has question on the diagnosis of metabolic syndrome, please write, or I move to the next question. So if you want me to move to the next question, please write proceed. If you have question, please write the question. So you can write proceed or you document a question if you have any question on metabolic syndrome. So this is how we are going to be answering the questions. Okay, I would like to reset proceed. Okay, okay, good. So let's proceed. So the next question, pay attention. Is a 19-year-old that presented to the emergency with polyuria polydipsia. The patient and body weakness. The patient was uh, had a BP of 110 beats per minute. No, sorry, the pulse rate of 110. The BP of 80 over 50. He had sodium of 148, potassium of 5.2, urea of 20 millimoles per liter, creatinine of 250 micromoles per liter, ketones of uh, 4 millimoles per liter. Ketones of 4 millimoles per liter. So let me repeat. Is an 18-year-old presented to the emergency with polyuria polydipsia, body weakness, pulse rate 110, BP 80 over 50, sodium 152, potassium 5.2, urea 20, creatinine 250, serum ketone level was 4. Okay, so the first thing I will ask you is, what is the diagnosis? So for you to calculate the diagnosis, that means you have to calculate the osmolarity. You have to calculate the osmolarity because this is the kind of scenario I ask when it comes to hyperglycemic emergency. And additionally, sorry, the blood sugar level done in the lab was 50 millimoles per liter. The blood glucose done in the lab was 50 millimoles per liter. You know, glucometer cannot read beyond 33.3. I think they asked some of you when they were discussing glucometer. So the glucometer cannot read beyond 33.3. So, what is your diagnosis? So, you have to calculate the osmolarity, then you tell me the diagnosis. So, please, if anybody has calculated, then you can write the diagnosis as I wait for you. So, I can give you the option. Option A, hyperglycemia. Option B is DKA. C is HHS. D is mixed HHS DKA. Then E is sepsis. So A is hyperglycemia, B is DKA, C is HHS, D is mixed HHS DKA, then E is sepsis. What is your diagnosis? So as I said, you have to calculate osmolarity. If you do not calculate osmolarity, you will definitely not get this question. And it happens like that. The exam officer like questions on DKA HHS. So it's important that you know this kind of question. Okay, I'm waiting. Adetola, Sumaya, Isa Yusuf, Abdullah Toro, give me answer. Why is Remam? I'm not seeing he didn't write anything today. So what is the answer? I'm going to give you guys 1 minute. If you don't say the answer, I will say it and explain. So you have few seconds. Okay, the values. I said the values of what? Is it the U and E? I said sodium 152. potassium 5.2, urea 20. Then blood glucose, I said, is 50. Okay, and then I say serum ketone level was 4 millimoles per liter. Okay, so Sumaya said the osmolarity is 3.7 HHS. Okay, I'd like to say HHS also. Any other answer? Any other answer? So I'll proceed. Okay, so the answer is actually mixed HHS DKA. The reason why the answer is mixed HHS DKA is because I told you that the serum ketone level was 4 millimoles per liter. If you remember vividly, the criteria for DKA, the serum ketone level should be greater than 3. And I said serum ketone level is 4. So that is a mixture of DKA and HHS. So it's mixed HHS DKA. And it usually carries very poor prognosis. So when you are managing this kind of case, you treat it like you're treating DKA. But the difference is that you have to add thrombolytic prophylaxis. So there has to be thrombolytic prophylaxis in it. So the insulin therapy will still be zero point 0.1 international unit per kg per hour. The fluid deficit, you have to treat it like it's HHS. You give 9 to 12 liters, right? But the insulin, you cannot give 0.05 international unit per hour. You have to give 0.1 international unit per hour. Okay, Wilfred is here. You're welcome. Then you have to also correct potassium if there is problem. So it's a mixture because of that serum ketone that is 4 millimoles per liter. Okay, Sumaya said, okay, that I told you that, okay, that I'm saying now. Some text said, if you remember vividly, I said some text say 5, some say greater than 3. So please, if you see any value greater than 3, all right, or 5, please use it. As long as it's not below 3 and below, just take it as DKA. Very important, please, because it depends on the text you're using. So it can be 5, some text say 5, some say greater than 3. But to be on the safe side, right, is better you use any value that is greater than 3 as your answer. Any value greater than 3, please use it as your answer. Okay. So but in the exam, to make it easier, so where to make it easier, I usually, like in your exam, I gave the value of 6. I gave the value of even 6 to even remove any confusion. And some of you still were choosing HHS. I gave the serum ketone to be 6, so that you will not say, it's not 5, it's not 3. 6, you see, 6 fulfills the criteria of both 5 and 3. Isn't it more than 3? Okay, so it's mixed HHS DKA. So you give the fluid like you're giving HHS, 9 to 12 liters, but the insulin you give it like you're giving treating DKA, right? You use 0.1 international unit per kg per hour, and you have to give thrombolytic therapy. Okay, so any question on that, or you write proceed? Any question for me on that, or please document proceed, and I can proceed to the next thing. If you have any question on this, any question, HHS DKA, please write. Okay, Adetola Road proceed. Okay, okay, Sumaya Road proceed also. Okay, any other one? Please try and remember the questions they ask you in other specialties. The ones you have recalled is not good enough. Oh. You know, my questions were easier, but you remember some questions were a bit tougher, like infectious disease. And which one? Which questions were a bit tougher? Please write so that I can have a discussion with the people if they can make their questions more clearer. Which questions, which specialty were a bit tougher or less clear? You know, my questions are very clear. It's either you know it or you don't know it. Okay, so Abdullah Toro said dermatology. Okay, noted. Gastro also. Adetola wrote gastro. Okay, okay. So gastro is the HOD now. Ah, a lot of people are writing gastro. So that means I will discuss with Oga. Okay, it's all right, no problem. So let's proceed to the next question. Okay, so the next question is a 19-year-old. A 19-year-old presented to the endocrine clinic uh, because she's worried that more than half of what are gastro cases, the difficult ones, right? No problem. I think I'll see how I can discuss with the HOD. How he can make his questions a bit clearer. Okay. So, as I said, a 19-year-old, please let's pay attention. 19-year-old present with the endocrine clinic because she's worried that her sister has type 1 and she wants to know the risks of having type 1 diabetes. Okay, so you did test, her blood glucose is 6.5, fasting blood glucose was 6.5 millimoles per liter, and the anti-GAD antibody was positive, anti-glutamic acid decarboxylase was positive, and as I said, the fasting was 6.5. What stage of type 1 diabetes is she in? Is she in the honeymoon period? Stage 1, stage 2? Is she having overt type 1 diabetes? Or she is in stage 3? So A, honeymoon. B, stage 1. C, stage 3. D, overt type 1 diabetes. E, stage 2. E, stage 2. So what do you think? GAD, anti-GAD was positive, fasting 6.5. Okay, so for some of you, anyway, let's attempt the answer, then I can add some things to it. Attempt the answer, then I can add one or two things. Okay, if I say honeymoon, okay, any other person, any other attempt before I explain? So it is extremely important. Okay, I said the option A, honeymoon period, B, stage 1, C, stage 3, D, over type 1 diabetes, and E, stage 2. Okay, so please, let me explain something. All right, there are stages of type 1 diabetes. One is if the stage 1 is a situation where the individual has detectable autoantibodies, but the blood glucose is normal. Pay attention. So stage 1 is when you have detectable autoantibodies, but the blood glucose is normal, which is not the case here. I said the fasting was 6.5. Stage 2 is when you have detectable antibodies, but the patient has pre-diabetes, either impaired fasting or impaired glucose tolerance, which is the case because 6.5 is impaired fasting blood glucose. As I said, you must know this thing. What is normal blood sugar? What is pre-diabetes? What is diabetes? So fasting of 6.5 is impaired fasting glycemia, which is stage 2 of uh, type 1 diabetes. Then stage 3, which is over diabetes, they mean the same thing, just to confuse sometimes, is when the individual has detectable autoantibodies but fulfills the criteria that defines diabetes. That means the fasting is 7 millimoles and above, or the random is 11.1 millimoles and above, right? So this one fulfills the criteria for stage 2 of type 1 diabetes. So she's at risk. And people that have stage 2 are at risk of going into stage 3 within 3 to 5 years. So within 3 to 5 years, she can easily go into stage 3. Okay? Any question on that? Or you want me to proceed? Any question on that, or should I proceed? Please type. Okay, I want to know questions or proceed. Please type. Or it has to be very interactive, don't it? As I said, oh, okay. It is an anti-mono mononuc. What do you call those ones? Antibodies. It teplizumab, right? It's teplizumab. It slows the progression, though it has not been. It's just recently approved by the FDA. Monoclonal antibody, yeah. So teplizumab. Oh, so that's it. So honeymoon period is somebody that has been diagnosed with type 1 diabetes, but the fact that the individual still has residual uh, beta cells. You see that when the individual has any infection, you develop DKA. When you treat it, you see that the individual does not require any insulin. I've had a patient like that because he still has residual insulin production, because the autoimmune destruction of the beta cell is not really total yet. And sometimes honeymoon period can take up to 3 to 5 years. So, but whenever they have anything that puts a demand on the beta cells, they will develop DKA, hyperglycemia. But once you treat them, that the trigger is out, they don't need any medication. So honeymoon period is a period in which someone with type 1 diabetes still has some residual insulin production that does not require insulin to have normal blood glucose, except in the period of a trigger such as infection. Hope you understand, Wilfred. So that one is different from somebody that is in stage 2. People in stage 2, they don't have any problem. It's just having pre-diabetes. And most pre-diabetes are asymptomatic. Very few come with neuropathy and slight symptoms of retinopathy. Okay. Any other question before we proceed? Or if no question, please write proceed. Wilfred, And Sir AB, right, proceed. You that ask questions. I don't want anybody to be left behind. By God's grace, nobody will have issues. For me, mm, on my own part, I will do my best for you people. Can only do my best. Okay, so proceed. Everybody has written proceed. Okay. So for next question is a 55-year-old woman, a non-diabetic patient for 15 years. She's on metformin 1 gram BD and glibenclamide 10 milligram daily. She presented to the A&E with generalized tonic-clonic convulsion and loss of consciousness. You do random blood glucose and it was 2.0. She was treated with intravenous dextrose containing fluid and she totally recovered. So, what do you do for the patient? What do you do? Let me repeat again. 55-year-old woman, non diabetic 15 years, on metformin and glibenclamide. Metformin 1 gram BD, glibenclamide 10 milligram. She came with convulsion and loss of consciousness. The random blood glucose was 2.0. You gave her dextrose and she regained consciousness. What is the next step? You discharge the patient home or you maintain on dextrose containing fluid for 24 hours or you stop all anti-diabetic drug and you give dextrose containing fluid for 48 hours. You stop all diabetic drugs and discharge home. Which one is the answer? So A, discharge home. B, maintain on dextrose for 24 hours. C, stop all anti-diabetic drugs and maintain on dextrose for uh the B is maintain on dextrose for 24 hours. C, stop all anti-diabetic drug and maintain on dextrose for 48 hours. Then D, stop all anti-diabetic drugs and discharge home. Okay. So Sumaya says C, yeah, exactly. So Sumaya, why do you say C? Someone should write the reason why you think it should be C. Why should it be C? Why do you think it should be C? I need reasons. So that if they twist the question, you will still get it. Why do you think it's C? Type it because the duration of action of metformin is 36 hours. Okay. Wilfred, because glibenclamide is sulfonylurea. Yeah, so is the glibenclamide and the action of glibenclamide is at least the duration of action of glibenclamide is at least 48 hours. Metformin, if it's the metformin that causes the hypoglycemia, you can treat for 24 hours, right? But the glibenclamide lasts up to 48 hours. So that's right, Wilfred. Okay. So anyway, does anybody has seek any clarification on hypoglycemia? Please seek it now before we go to the next question. Any question on hypoglycemia or we move to the next question? Any question on hypoglycemia or we move to the next question? If no question, please be writing proceed for me, okay? All right, Isa Yusuf wrote proceed. Any other person wants to write proceed? Okay. Okay. Wilfred also ripos it. Still on the management of hypoglycemia. If if after fluid therapy and the patient is still unconscious, what do you do? So if after fluid therapy the patient is unconscious, if you have corrected the hypoglycemia and the blood glucose is more than or equal to 4 millimoles per liter, you maintain on 10% dextrose water 1 liter 8 hourly, right? So it is possible, depending on the duration of the hypoglycemia, that the individual has already developed neuroglycopenic coma. That means that brain damage has already occurred. So you maintain on dextrose containing fluid, and you maintain on dextrose containing fluid, and you call the neurologist to assess if the patient has already developed brain damage or is in a vegetative state. And if it's already in a vegetative state, there's nothing you can do. That's how serious hypoglycemia is. That's why the best thing you can do for hypoglycemia is to treat it. The sooner the better. Adetola, what do you, okay, come again with what now? Be specific so that I can know what you missed. Sumaya, did you get what I said? No, see, glucagon, right? Glucagon is glucagon is it depends on the cause of hypoglycemia, because if someone has glucagon, you're depending on the fact that the liver function is intact. Glucagon can only be useful if you have um, intact glucose, what is it, sir? Intact liver function. But glucagon is not faster than dextrose containing fluid. Glucagon is not going to do magic, right? As I said, if you give corrected and the patient is still unconscious, even if you take it to ICU, it makes no difference, right? Because as I said, you call the neurologist to assess if the patient is vegetative state. If the patient is vegetative state, there is no magic that the ICU will do, right? You and me, Sumaya knows that if somebody has already developed uh, permanent brain damage, is there anything you can do? As long as the brain damage is not permanent, the patient after giving dextrose, Whipple's triad, he should wake up, right? So glucagon is one of the things that you can give initially, especially someone who has good liver function, and you can give it in diabetes patient actually, but you don't have it readily. So to me, if you are discussing, right, management of hypoglycemia, the best thing is when you assess, you give dextrose containing fluid, right? Where you do not have IV access, pay attention. Where you do not have IV access, then glucagon is a very good option, right? But if you have IV access, right, dextrose containing fluid, what does glucagon do, Sumaya? Glucagon stimulates the liver, it stimulates glycogenolysis. So is it not breaking down of glycogen to produce glucose? So if you give that person glucose, which one is superior? But situation where you have lack IV access, glucagon can do that, because glucagon you don't give it IV, it's IM, and that one will afford you the process of production of glucose via glycogenolysis. But you have IV access, the best treatment of hypoglycemia is the dextrose. So if the patient does not wake up, right, you assess if the patient has developed neuroglycopenic coma, right? And if the patient has developed neuroglycopenia, of course, I don't have a problem with taking him to ICU, right? You can say it, but it will not make any difference. Ask the neurologist. If the patient has, you can keep. Like people that have developed vegetative state, if you take them to ICU, you're just prolonging their stay, but you cannot reverse it. So what's the use? So for hypoglycemia, right? You any patient that comes with hypoglycemia, get IV access, give them dextrose containing fluid, and as I said in my our last meeting, that you give 150 mils of 10% dextrose, because it has been observed giving 50 mils or 50% dextrose in double dilution is slow, is cumbersome, while giving 150 mils of 10% dextrose, which is about 15 gram of glucose, is faster and yields more result. So that's how you answer, because some of those my colleagues, they are not in endocrine, so they don't know the letters, isn't it? So you balance the letters plus the old, right? After correcting with the dextrose, then you maintain on 10% dextrose water 1 liter hourly, right? If the patient does not wake up, likely he has developed total brain damage and permanent brain damage, which the ideal thing is to invite the neurologist to assess. And most of the invitation I have given to the neurologist, actually, well, they don't do anything. They counsel the patient that there's nothing they can do, right? That let them just pray and hope he wakes up. I have not seen one that has permanent damage from hypoglycemia that woke up. I have not seen up to today. They will just become like a vegetable. So, but if they like to take the patient to ICU, they can do that, but they should know that that won't reverse the brain damage. Okay, so can I proceed now? Did I clear the air? Please write if I can proceed. Okay, Sumaya, you understood? Okay, yeah. So, Sumaya, as I said, it's not that glucagon will do one powerful magic and the patient will wake up. Still, glucagon will just help with the production of glucose. It doesn't do any magic, right? Okay. So, next question. Next question. A 25-year-old woman presented with a year history of anterior neck swelling. She presented with a year history of anterior neck swelling, palpitation, heat intolerance. Okay. Palpitation, heat intolerance. Okay. Her pulse rate was 120 beats per minute. She had a moist, sweaty palms. She had a ophthalmos. Okay. The anti-thyroid peroxidase antibody was positive. The thyroid stimulating receptor antibody was also positive. So what is your diagnosis? I don't need to give you option here. So 25-year-old, anterior neck swelling, heat intolerance, palpitation. She has sweaty palms. The pulse rate was high. She has some sort of thalamus. What do you and the thyroid peroxidase antibody was positive. TSH receptor antibody was positive. What do you think is the diagnosis? So write it. Okay. So okay, Graves. All right. So it's Graves disease. Wilfred, why do you think it's Graves disease? Because I asked you people this question in your picture test, and a lot of you feel like, "Ah, I wasn't happy. I wasn't happy at all." I was not happy. Why do you think it's Graves' disease? Let's use the opportunity to discuss questions on Graves' disease that I asked during the picture test. Why do you think it's Graves' disease? Wilfred, I'm waiting for you. Abdullah Toro, I'm waiting for you. Why do you think it's Graves? Let me be sure you're not guessing. uh-huh. Yusuf, Isa Yusuf, pay attention. It's not TSH antibody, oh. It's TSH receptor antibody. Most of you wrote TSH antibody. You know, TSH antibody, there's inhibitory and stimulatory. So the one that is stimulatory is TSH receptor antibody. Is TSH receptor antibody. In your picture test, you people wrote TSH antibody. That's not the answer, though I gave some people half of that mark. But it's TSH receptor antibody. Don't forget, right? Okay. And what are the modalities of managing Graves' disease? It's one of the things I have asked during. So it's TSH receptor antibody. What are the modalities of managing Graves' disease? So one of the questions I asked during your short case, I asked people that question. Your short case, I asked it during picture test in your mock. Okay. So what are the modalities? Okay, Sumay wrote medical and surgical. Any other person? Any other person apart from Sumaya? These are the questions that they are going to repeat for you. They will not bring questions from the sky, and I'm not sure they will ask me to write in new questions. So it's better you sort out this, it's better. So apart from medical and surgical, any other modality? I'm waiting. Medical and surgical. Also, Sir AV wrote that. Any other person? Okay, let me come in here. So I agree with medical and surgicals, but there is medical, there's radio iodine therapy. A lot of you wrote radiotherapy. It's not radiotherapy. Medical, radio iodine, and surgical, right? So medical is the one that you give the thionamides, you give propanolol, right? Surgical, you do thyroidectomy, whether subtotal or total. Then radio iodine therapy is one of the treatment that after you make the patient you thyroid, whether it's toxic mononuclear goiter or even Graves, you can give radio iodine. Please, it's not radiotherapy. It's radio iodine therapy. Okay? And I remember, don't forget, one of the serious side effects of the thionamide is agranulocytosis. Agranulocytosis. Well, some of you were writing itching, nausea, and vomiting. No, it's agranulocytosis. Okay. So, any question on thyroid? Do you have any question on thyroid? The next will be calcium metabolism. Any question on thyroid? If no question, right, proceed. Let me go to calcium. You people have short time, so today we need to iron out anything endocrine so that tomorrow we can go to another system. Any question on thyroid? Okay. So Maya wrote proceed. Okay, proceed. Good. So, okay, we are being asked about mechanism of action and antithyroid organism, antithyroid drugs. Okay, so the mechanism of action of antithyroid drugs is they inhibit the thyroperoxidase enzyme. If you, I shouldn't be the one teaching you thyroperoxidase. What is its role? You know, it's required for uh, organification, coupling, even the iodination. So it inhibits thyroperoxidase enzyme. That's the mechanism of the thionamides. Okay. So I'll ask question about anterior nasal. I said all these things, but the HOD didn't accept. What, especially the differential diagnosis. So the differential diagnosis, pay attention. An individual has if you think the individual has thyrotoxicosis, the first is Graves' disease, second toxic adenoma, third toxic multinodular goiter, right? These are the things: toxic adenoma, Graves' disease, toxic adenoma, multinodular toxic multinodular goiter. Then if they ask you to add, then you can say early phase of Hashimoto disease, early phase of subacute thyroiditis. But these three that I've mentioned earlier, Graves' disease, toxic adenoma, toxic multinodular goiter, they're the three differentials of hyperthyroidism, right? So which question did he ask you? Which question particularly did he ask you? I'm waiting to see. Aisha. Okay. Aisha, was it during orals or during short case? You know, anything that anybody asks you, if you can't defend it, that's where the problem comes. Was it during short case or long case? Good. So if it is during short case, this is what you say, Aisha, that this patient has osophthalmos, it has sweaty palms, he has tachycardia. If he has, I didn't see the patient, right? Did you only examine the swelling or you examine other things? So you say that a patient with thyroid will not have osophthalmos, will not have tachycardia, will not have sweaty palms. Is your ability to defend, because thyroid should not have tachycardia, should not have sweaty palms, should not have osophthalmos, isn't it? Or is it just the swelling that you examine? Because if it is just the swelling, then you can mention thyroid thyroid cancer, or you did just thyroid examination plus the eyes plus pulse rate and other things. What did you do? Or was it that picture that showed somebody with protruded eyes? Like, okay, okay, it was the one in the laptop. Aisha, I'm waiting for you. Was it the one they showed in the laptop? Okay. Aisha, I'm very sorry for what happened to you. But it is because of your inability to, it was because of your inability to defend yourself. If I was you in your shoe, I would say, sir, I can see the sclera below the lower limbus, showing that the patient has ophthalmos, and thyrosis should not give ophthalmos. There is nobody in this world that will not keep quiet if you said so. So, sometimes uh, some of your examiners it may not be their specialty, but if you show that the process of both long case and short case, I have said before, is your ability to defend yourself, right? Your ability to defend yourself. So don't worry, when we come to clinicals, I'll guide you on some of these things, right? But your ability to defend yourself is extremely important. If you say, okay, sir, from the picture test, I can see the sclera below the lower limbus, indicating likelihood of ophthalmos, and thyroid 6 will not cause ophthalmos. That's why I did not say it. And thyroid cancers also, unless if it is a toxic multinodular goiter that transformed to cancer. Otherwise, thyroid cancers also shouldn't cause ophthalmos. There is nobody in this world that will fail you. So it is important that you learn how to defend yourself, even in the heat of exam, because your life depends on it, isn't it? Okay, hope you understand, Aishat, so that I can proceed. Right, I understand. Or you have more questions for me. Okay, all right. Okay, so let's go to uh uh let's go to hypocalcemia. I'll try, because we have almost spent 1 hour. I'll try to summarize hypocalcemia for you people. And okay, apart from thyroid, differentials apart from thyroid, that's serious. Okay, differentials apart from thyroid, it could be anterior neck abscess. It could be anterior neck abscess, right? But that is totally unnecessary. It could be lymph node enlargement. It could be lymph node enlargement. But sincerely speaking, that's totally unnecessary, because I selected that patient because there's ophthalmos and neck swelling. Why should someone be asking you apart from thyroid? Yeah, that's not fair. But that's exam generally sometimes is not fair. But you can think of structures in the neck that can get abscess now. So anterior neck abscess, it could be lymph nodes, neck lymph nodes that have swollen, right? So it can be that. We selected, I don't know why they are making interpretation for the things I have selected, right? But if they wanted you to say other things apart from thyroid, then you say anterior neck abscess, it could be lymph node enlargement. But all those ones cannot give you ophthalmos, right? So I think one of the things that I will insist on, Sabi, Aishat Haruna, and the rest, is there has to be an examiners meeting where certain questions or pictures we can reach a uniform the specialist can give an idea what he's looking for, so that other examiners will not be looking for what is not there, right? So exam, and me, I ask. So it depends on who you meet in exam. So you should also pray that whoever you meet in exam will not make your life difficult, isn't it, Sir AB, Aishat? So you always pray that, because the purpose of that picture is for you to be able to see that there's osophthalmos and it's likely Graves' disease. It's not to look for other causes of neck swelling. We are not surgeons, right? We are physicians, right? So as I said, always pray that you find it easy in exam, that because your examiner's thought may be differ from your own thinking. But on my part, what I will do is that I will insist, and if I will be, though I'm on leave now, but by the time you're doing exam, if I'm back, I will insist on examiner's meeting, so that any picture or any picture that will be shown to you, the person that said the question should give us an idea what he's looking for, so that there will be uniformity in the question, right? Because I don't want you people to fall victim of somebody's separate idea from what the person that said question is asking. Okay, so that's what I will do for you. So here, when is the exam? If it's in January, I'll be around now. Is it in January? If it's in January, I'll be around. I'll be around. Don't worry. By God's grace, I'll be around. Eh? And pray that you meet me. I'll not be biased, but I'll be objective, isn't it? So put it in your prayer. Now I should be the one that will meet you. Okay, please allow me to talk about calcium before we finish for today. Okay. So this sign, capopida, this if somebody has spasm like this, flexion of the ribs, flexion, adduction at the of the thumb, and some flexion of the at the mecaptophalangeal joint, that is capopida spasm, isn't it? And we say that it is Trozel's sign. I asked that question, right? And if the calcium is, please go and read, eh? Go and read the different values for mild, moderate, and severe hypocalcemia. So if it's severe hypocalcemia, you give uh, 10 mils of 10% calcium gluconate in 100 mils of uh, normal saline to go within uh, 10 minutes, 10 to 20 minutes, and you repeat it until the symptoms have subsided. Then you maintain on 100 mils of calcium gluconate in 1 liter of normal saline to run at 100 mils per hour, right? But if it's not severe, you give the patient any calcium source of any tablet, and also the patient should take calcium rich food, right, such as egg, fish, milk, and the rest. And me, you prefer giving calcium tablets that are both combination of calcium, vitamin D, and magnesium before you do your test and have a definitive result, right? So please, if that picture test comes again, please, none of you should fail it. You describe what you see. What is it called? Is capopida spasm? What is the sign? Trozer sign, right? Then you make the diagnosis and treat. For the diagnosis and treatment, Let me give you a scenario. Please carry your pen and paper. I don't want you to fail again. There will be calcium. So make sure your pen and paper is ready. If you have low calcium, normal phosphate, right? High parathyroid, low vitamin D. What is it? Oof, my phone is down. Sorry, I think we'll have to continue tomorrow. My phone is down. Sorry about that. We'll continue tomorrow.